Hello, and welcome from the Integrated Food Safety Centers of Excellence. My name is Paula Huth, and I will be the moderator for this session. I am an epidemiologist at the New York State Department of Health and coordinator of the New York Food Safety Center of Excellence. We thank you for joining us on today's webinar, which will showcase several online complaint systems. This webinar will highlight the aspects of successful online complaint systems, which may assist other state and jurisdictional health departments with their own online complaint system development or advancement. Each state uses a different platform to run their system, which will also be discussed. We have speakers today from the Rhode Island Department of Health, Maryland Department of Health, Utah Department of Health and Human Services, and the Wisconsin Department of Health Services. Each will present on how their particular system has been developed and implemented, how it has been successful in supporting enteric disease response activities, and any lessons learned or best practices for implementation. After presentations, we will open the floor to any questions you have about online complaint systems. We will only be using the Q&A box to receive questions. So please enter any questions you have into the Q&A box, and you can do that at any time. We're going to take questions at the end, but feel free to enter them into that feature as they come to you. Note that this webinar will be recorded, and we will post it to the Food Safety COE website once it's available. With that, I would like to pass it over to our speakers. So first up, we have Christopher Slayton. Chris is an epidemiologist at the Rhode Island Department of Health and has been in this role for about 4 years. He is the Rapid Response Team Coordinator and manages foodborne illness complaints reported to the State Health Department. Thank you, Chris.
All right, awesome. Can you guys hear me and see me okay? I think my camera might be a little far out, but that's okay.
Looks good. Yep.
Okay, perfect. Yep. All right. So like Paul said, my name is Chris. I'm an epidemiologist here at the Rhode Island Department of Health, and I basically do everything with our complaint system. I think I take like 99% of our complaints, at least foodborne complaints, I should say. Not all of them. I don't want that. Without further ado, I'll get started here. We're kind of just going to do a general overview of the complaint system and how we developed it and how we use it. So we use DHD, which is run by Tyler Technologies. It's a third-party software company that their main purpose is kind of to provide the public sector with just software in general. And this is what we do our licensing through as well, or part of how we do our licensing, which is what I'll bring up a little bit later. But so we started doing online complaints in 2019. So we've had it for about 5 years now. I took a bunch of our paper complaints and entered them into the system. It took me, months. I think we had like 10 years worth of data, or maybe more. We had an internal data analyst and 2 vendor-provided developers work on the project, at least developing it. And for our internal data analyst, it took about 5 hours a week of kind of working with me and working with some of the other people here at the Center for Food Protection on what we needed out of the complaint system, anything we needed, and kind of going through the development process. That took us about 6 months. And that data analyst is the dedicated staff we have to maintaining that system. And it only takes him about an hour a week. He doesn't really have to do a ton because I do a lot of the maintenance right now, but it takes him about an hour a week. And I guess as far as reviewing and responding to that information that we put into the system and everything like that, it takes me about 10 hours a week. We average about 1 complaint a day and a few other things that go on with the system and things that need to be done. All right. So I wanted to bring up some quick strengths and kind of considerations for the system. They're very general and things I think most people would kind of recognize right away. But it is an online database. And so because of that, we can kind of export all of our information and data into any format that we like: Excel, SAS file, SPSS, anything that you want. But that's kind of a double-edged sword because it does go offline occasionally, right? And so I think the servers are based in Texas. So anytime that there's an issue in Texas where they might lose power, we lose our servers for a short amount of time. Not the biggest deal, something we deal with in this modern age, but something to consider at least. Have some paper copies on hand, right? It allows us, because we're able to get everything online in a database, to kind of have metrics. And I'll bring up a few of those later on, and kind of lets us to do a little bit of, I guess, more robust data analysis on our complaint system to look at, demographic information, things we might want to change, and any information we want to get out of it. It also links to our licensing software, which I think is a big plus. it allows us to link the complaints to the licenses in DHD. And then because we use a risk-based assessment strategy for our inspections, the complaints will get factored into how frequent an establishment will actually get inspected. So it's not weighted super heavily because you can have complaints that aren't always the most legit, but it is weighted in there. And I guess two other things to consider are training and funding, right? So if you have to train somebody to use the online complaint system, which is something I do pretty regularly for a lot of the people here at the Center for Food Protection, and funding. Because we use a third-party complaint vendor, we do have to keep that kind of like maintenance funding and a few other things throughout, right? And if we want to update anything or change anything, sometimes it does cost money. All right, and then moving on. So I just wanted to bring up a few things. There is a lot of data you can get out of an online complaint system through data analysis and other stuff. But I think the biggest thing for us is 78% of our foodborne outbreaks are detected through our complaint system. Not necessarily specific to it being online, but that's something that definitely helps, right? We're able to kind of track that metric over time much easier through the online complaint system. And this is just kind of a general thing that I track, right? So in 2022, 71% of our complainants were female. And another thing that I think is super interesting is in 2022, 43% of our complainants were still sick when they called in to submit a complaint. And all stuff that's really easily for us to pull from an online complaint system, right? It's basically just almost a table that's automatically generated for me, right? Instead of having to go through manually and kind of calculate this stuff myself, it's kind of just there for me, which is I think really useful and saves me a lot of time. All right. And so to kind of get into the complaint system a little bit more, complaint submissions can be online or by phone. We have an online portal, or you can come through the main line and get transferred to me. This is just kind of a graph of how the complaints are submitted over time. Over time, it's overwhelmingly been online. I think this past year we only had like 30 phone complaints and we had 260 complaints. So that's changed over time. It's been a general trend for us. And so I wanted to just kind of show our actual forms for some of our complaint systems, right? So when you submit a complaint before we actually do the interview, before I call and interview somebody, this is what we have online, right? So we just kind of get some general demographic information, food establishment details, illness, symptoms, and any other, valid information that we think that we might want. It's pretty short and to the point. It kind of lets us follow up on the complaint regardless of if we can get in contact with that person. And then we're going to hop into the form here. And so I'm not going to go into everything on here, obviously, as well. But like I said, it kind of keeps it general with demographic information, suspect meal, symptom information, how many people are sick, other ill individuals and their contact information. And then, medical care, food history, and other exposures. We like to do things, are you a healthcare worker, food care, anything like that. International travel, because that's important, recreational bodies of water, any large gatherings to kind of give us an idea of if there's any, maybe expanding issues that we might see here. But I kind of wanted to keep it short and to the point. If you have any questions, here's my contact information. And yeah, thank you.
Great, thank you, Chris. Our next speaker is Erin Kafka. Erin is the Rapid Response Team Coordinator at the Maryland Department of Health and has been in this role for nearly 4 years. Prior to that, she had a career in industry. Her main responsibilities include the environmental health portion of outbreak investigations, complaint coordination, and laboratory flexible funding model sampling and follow-up. Thanks, Erin.
Hi, everyone. Can you see my screen?
Yep, it looks great.
Okay.
We can hear you good.
Great. So again, yeah, thanks for the introduction, Paula. I am the Maryland Rapid Response Team Coordinator. So I will just give some updates on our recent complaint system that we have implemented. So this is our mission and vision at the health department. So our regulatory structure, sorry, I'm just trying to move this out of the way. So we're a decentralized state, and Maryland Department of Health is the delegated authority to regulate food within the state. So our Office of Food Protection, which is where I am located, is the primary agency that has the regulatory authority over food protection, and that includes food manufacturers and distributors. Local health departments have the delegated authority through the health secretary to regulate retail food service facilities such as restaurants, supermarkets, institutional settings, and I'll get into that a little bit more in a minute. And regulatory authority just includes inspections and investigations such as complaint and foodborne outbreak investigations. So the old way. So prior to the pandemic, our office just received complaints on paper. It was like in a complaint binder and then just assigned to the appropriate environmental health specialist for follow-up. This was just people calling our office and complaining and then not really getting, any follow-up, just hoping that the complaint went to the right person. So the complaints were usually just directly forwarded manually to the local health departments and not sort of recorded. And the responsibility for complaint processing was primarily our administrative office staff and supervisors in our office, our section heads. And like I said, there was no real ability to track complaints efficiently at the local or state level. So, where did the complaints go? What follow-up occurred? Were they investigated by the local health department? We didn't really know. So during the pandemic, the number of complaints dramatically increased. We had moved to Google Sheets just, during the pandemic to more efficiently process and track the complaints. But once COVID restrictions and executive orders and, for social distancing and masking were issued, then the local health departments became quickly overwhelmed by the number of complaints they were receiving from citizens. Our office went into a modified incident command structure to try and manage this. Teams were set up, with one being a complaints coordination team. So they brainstormed ways to make complaint processing easier, assignments and responses more efficient and just consistent across jurisdictions, because that's another issue. Some of the counties respond differently to some of these complaints. So we decided to work with Cognito, which is a cloud-based platform. It was already being used by other bureaus within Maryland Department of Health. A link was created and placed on the Maryland Department of Health website, which was, made it accessible and easier to use for consumers. Data fields are unlimited and customizable. Complainants have the ability to upload pictures and videos. Administrative users have the ability to run reports. Trends are easily visible. So it's interesting to me if I can see, like, we're getting a lot of complaints about Chipotle, for instance, but not the same location. We can then delve into that, why that might be happening. And then complaints could be forwarded directly to the local health departments automatically through the system. So we reached out to each county and asked for 2 contacts for each county. And when the complainant selects the county where the facility is located, then once the complaint is submitted, a copy of that is automated directly to those people. So initially, Cognito was used to manage COVID complaints and complaints that were a responsibility of the local health departments. Then we moved from Google Sheets to Cognito. A primary consumer complaints coordinator was assigned to manage the complaint system. So that is me. I communicate with complainants if additional information is needed. I can make sure that we can, properly assign a complaint and that follow-up is given. And most of the complaints that we receive are complaints that are handled at the local level, like for retail type facilities. But that way I can at least send an email to the person and give them a phone number and email a way to follow up with that local health department, and they can, check on the status of the investigation. And again, as I mentioned, it allows us to look for trends and act as a liaison with the local health departments, FDA, USDA, depending on the type of facility. So once we discovered that this was working well, we developed a new SOP. And this is just a back-end user view of what the reports look like, and when complaints come in, we can, it's pretty easy to see what's going on. And then this is the user view. You can see the fields that are required, and it depends on the type of complaint. Sort of like in the last presentation, if it's a foodborne illness complaint, if it's a complaint about facility conditions, you get different drop-down boxes that appear based on your selections. And here's just an example of the choices: facility sanitary conditions, product issue, cottage foods, which is newer, but is an exploding area. So we do get a lot of complaints about cottage foods. And this allows us to track that too. So complainants just select the type of complaint that best matches their issue and, go through the drop-down menu. Questions and data fields are specific to the complaint type selected. Once the complaint is submitted, it's then routed to the, particular staff. And then an example of that is, a foodborne illness complaint is then routed to epidemiologists in Maryland Department of Health Division of Outbreak Investigations. So assignments sort of occur as follows. Complainants are prompted to choose a jurisdiction where the location of the complaint occurred. Once selected, the complaint is automatically routed to the designated email addresses for that county. If it's a retail facility, like I mentioned before, I just make sure that it's properly referred, and then I mark that closed. If it's a manufacturer or a distributor, which is a facility that we license, I then notify one of the supervisors in our office, based on where the location, who it's assigned to. And it's then assigned to an area environmental health specialist for follow-up, and is marked in progress until the investigation is closed. And I like to mark things closed once I can get a copy of our inspection report, and I will upload it to any pictures and video, along with any pictures and videos that are uploaded by the initial complainant, and then we have all the information in one place. So forms can be saved as a PDF and then emailed as an attachment, and anyone with admin rights can create a new form and input information directly when a complaint is received via phone. So we're getting, occasionally complaints via phone. It's not typical, but that is a way, especially if people want to remain anonymous for, current or former employees of a location. They may want to just, have call, and that way there's less way to track. So, and this just gives the results. So 2020, you can see that the number of complaints was low. That was before Cognito was used. And then you can see that we have been on an upward trajectory since then, which I think is good. It shows that we are, reaching more people. So, and then 2024 is on track to exceed 2023. So just some advantages, disadvantages. Advantages are that it's a single system that's customizable, used to process and manage all complaints received by our office. The consumer complaints coordinator is assigned and ensures that all complaints are, appropriately routed and completed and closed. You can detect trends. This system, Cognito, is very reasonably priced. According to our IT department, she said it's a very good system. We get a decent amount of licenses. So disadvantages, so some of the local health departments, like especially the larger ones, use other methods to process and manage complaints at the local level. So we don't capture all of the complaints in one system. We're just capturing some of the complaints that are received at the local level, and that's because we're a decentralized state. And lessons that we learned were, we want to make sure that the local health department contact list is regularly updated. We have people retiring all the time, leaving. So you want to make sure that that is regularly updated, and you want to make sure that there's at least 2 contacts per jurisdiction in case someone is out. A few jurisdictions have email boxes that are checked by multiple people, and those are the most ideal because it's going to a lot of different people then. you don't have to worry about people being out. And you want to make sure that the data fields are clear and understandable for the consumer. The types of jargon that we use, or letter abbreviations, they might not understand that. So that's just something to be aware of. And if you need to contact me, this is my contact information. And that is it. Thank you.
Great. Thanks so much, Erin. And I did see a question as for if when the states you guys are presenting, if you could just say if you're centralized or decentralized, if it's not already in your presentation. So Rhode Island is centralized, and Erin had mentioned for Maryland the decentralized nature. Next, we have Delaney Moore. Delaney is the enteric diseases epidemiology team manager at the Utah Department of Health and Human Services. Delaney has been in this role for 1 year and has been working in enterics for 7 years total. Her main roles include coordinating outbreak response, conducting surveillance, and managing grant activities. Take it away, Delaney.
Okay, great. Let me go ahead and get my screen up and get the presentation started.
And we can hear you fine, and I can see your presentation just in slide view.
Is it in regular view now?
It's not in the presentation mode, but it's definitely big enough that it's fine if you go through this way. It's just showing on the panel on the left, the like individual slides, a little version of them.
That is, it's a little strange. Hang on. Okay.
As
Okay.
long as you can.
There we go.
Oh, there we go. Perfect.
Okay.
Yep, you got it.
Thank you.
now.
I'm not normally a Zoom user, so thanks for your patience. Okay. So a little bit about Utah's online complaint system. I got sick. We started doing online complaints back in 2013. So we've been doing this for quite some time. And when we started this, we originally housed it in an internal secure website called PH Access. It had a nice little survey on the front end, and on the back end, our local health departments, their epidemiologists and their environmental health staff, as well as state employees, could see the complaints. And it worked fairly well for the first 9 or 10 years. There were some issues with complaints getting duplicated every time we tried to share a complaint between a jurisdiction. So say if someone lived in Salt Lake County and ate in Davis County, it would create a duplicate one. So there was a lot of deduplication there, and it wasn't super well connected with our routine surveillance system, but overall it kind of worked. About 2 or 3 years ago, though, we were informed by our IT and informatics partners that this website, PH Access, was no longer secure and that they were phasing it out. So we needed to move our system out of PH Access and into something else. So what we ended up doing was moving our system into 2 parts. So we have a REDCap survey on the front end. Most of you, I'm sure, are familiar with REDCap. And then on the back end, our data is transferred from REDCap into EpiTrax. This is our regular NEDS, communicable diseases surveillance system. And this link between REDCap and EpiTrax was actually set up during COVID and was done for COVID contact tracing. Our poor contact tracers, as you know, had way too much to do. So they ended up creating these online surveys that they'd send out via REDCap, and then all that COVID data would get shoved into EpiTrax. So that way we didn't have to talk to as many people. And we've capitalized on that and used that same connection now for foodborne illness complaints, as well as our, I think it's our crypto cases. We have an option for that as well. So we started using this new combo system of RedCap and EpiTrax in September of 2022. We had one informaticist and one epidemiologist who were kind of our dedicated point people for developing this. We also had a software developer that would jump in occasionally when we hit roadblocks. As far as developing the system, our informaticist spent about 5 hours a week, mostly just creating the RedCap form and making sure it linked up nicely with EpiTrax on the back end and that all the data transmitted correctly. And our epidemiologist spent about 2 hours a week just working with the informaticist, updating the form, making sure everything looked right, those kind of things. The development time overall was about 8 months. A lot of this was due to just craziness, honestly, and varying priorities. We would get a couple really good weeks of work in on this, and then something will pop up, especially on the informatics side, and we won't be able to work on this for about a month. And then we'd come back and put in another 3 to 4 weeks of really good work, and then maybe we couldn't do anything again for a month. So that's why it took so long. I honestly don't think it would have taken that long if we'd been able to just work on it consecutively and not have so many random breaks. As far as maintaining the system now, it's still an informaticist and epidemiologist, and there's almost no time devoted to maintaining the system. It pretty much runs on its own, I will say, unless it breaks. Sometimes the connection between RedCap and EpiTrax has issues, and if it does, then it's pretty time consuming for our informaticist to fix it, but that is pretty rare, and most of the time we really just leave it alone and let it do its own thing, and it does it pretty well. Our informaticist spends about 30 minutes a week helping us export some data, which I'll talk about why we have to do that in a couple minutes. And we have an epi that spends about 2 to 3 hours a week reviewing complaints, making sure that the appropriate local health department is notified if there are any really concerning exposures or if there are potential outbreaks, things like that. So overall, the system has been pretty successful. Since we started our new RedCap EpiTrax combo system in September of 2022, we've had 1,300 complaints, and the system identified approximately 10% of our 2023 enteric outbreaks, which was really great. And we really love that this is integrated into our routine disease surveillance system. This comes with a lot of benefits. One, our epidemiologists at both the state and local health department level already knew how to use this system, so we didn't have to do a whole lot of training for that particular group. We also have the ability to link complaints to laboratory confirmed illnesses, and EpiTrax does this automatically. If a foodborne illness complaint comes in with the same name and date of birth and some other identifying features as, say, a Salmonella or a Campylobacter case, we get a little pop-up notification that says, hey, this might also be the same person as this Salmonella or E. coli or whatever case, which is really, really nice when people are getting tested. We're able to link that data really easily, or for lost to follow-up cases, a lot of times we'll send them a text link to I got sick, and they can fill that out, and then we can easily link that to their Salmonella or E. coli case that was lost to follow-up. We're also able to link complaints to outbreaks, which is really nice. We have an outbreak module in EpiTrax, and it allows us to link common source complaints together and keep track of them. And then the best feature is that we're able to share complaints really easily between jurisdictions, including our Department of Agriculture and Food. We've added them into the EpiTrax system, and it gets rid of that duplication issue. So instead of saying, you know, Bob Jones has a complaint in Davis County and Salt Lake County and Weber County, it's one complaint and it's shared with all 3 of those counties. So it gets rid of that duplication issue. And again, it's a system that our epidemiologists are familiar with, so they know how to share complaints with other jurisdictions really easily. As far as some lessons learned, the 3 main things I would recommend is first, get buy-in from all partners. I mentioned that our epidemiologists really enjoyed this system. Our environmental health folks did not enjoy it quite as much. They really liked the old system, and they had a hard time understanding why we couldn't just keep using that. We had a hard time explaining the data security issues. And I will say EpiTrax, the back-end part of our system, is a little more complex than our previous system used to be. So I think in retrospect, we probably should have spent a little more time training environmental health folks. We did do some virtual training with them, but I think it would have been great if we'd gone to some of our larger counties in person to help them get used to the new system. As far as setting up or modifying a system, plan out the time you think it will take and then double it. It's like a home repair project, right? It's going to take you longer than you think, and it's going to take 3 trips to Home Depot. It's going to take 3 trips to the informaticist and the developer every day, honestly. And just remember that you are probably one very, very small priority if you're working with an informaticist or a developer. At least for us, our informatics team is swamped with a million requests from a million different people, and everyone feels that their request or project is the most important. And sometimes it is. Sometimes developing I Got Sick was the most important things, but a lot of times it was not, and it kind of got kicked to the bottom of the list, which is okay. We just should have been a little more realistic about the timeline. And then the last thing I would say is plan for the features you have in your system, not the features you want. We set up our form in REDCap to have repeating fields, even though that's not a functionality in EpiTracks. And we were told, oh, don't worry, we're going to get that functionality in EpiTracks in a few months. And it's been a year and a half, and it just keeps getting pushed back. So I wish we would have been so optimistic and just said, you know what, we're going to redo the survey so it's compatible with both systems. And that way we aren't having to go in and export data in this crazy backwards way that we're having to do right now. But overall, it's been a really good change for us. It's really nice to have this dual system with a nice, pretty REDCap survey on the front, and then all the data in our regular communicable disease database on the back end. It's been a great change. With that, there is my contact information. Feel free to throw any of the questions in the Q&A, and we'll get to them at the end, or I'll try to answer them as others are presenting. Thanks.
Thanks so much, Delaney. Madhu is helping out by putting the links to the online complaint systems that we've spoke about so far, and they are located in the chat section. So our final speaker today is Karen Bigler. Karen is a foodborne disease epidemiologist at the Wisconsin Department of Health Services and has been in the role for just under 5 years. Karen enjoys collaborating with the Wisconsin Electronic Disease Surveillance System and data epi teams and finding ways to spend less time on routine data tasks and more time on outbreak and case investigations. Go, Karen. If you're talking, you may be on double mute.
Can you hear me now?
Perfectly, and we
All
can
right.
see your slides.
Excellent. Great. So again, my name is Karen Bickler, one of the epidemiologists here at Wisconsin Department of Health Services. I am just going to take a few minutes to kind of introduce our new foodborne and waterborne illness complaint tool. Here's a picture of our logo. We are using the kind of tag, feeling sick, report it quick. So just very briefly, I know we don't have a ton of time left today on the session, so I'll just kind of walk through kind of the reasons behind why we wanted to have an online foodborne and waterborne complaint tool for Wisconsin, just briefly how it works, and then some of the suggestions that we have given our decentralized state public health partners in terms of follow-up to these complaints that they receive, some of the lessons that we've learned throughout this process, and then the challenges that we sort of anticipate for the future, and some of the plans that we have in the back pocket to kind of address those anticipated challenges. And then lastly, I'll give kind of a rough estimate of the resources that have gone into creating this tool and into maintaining the tool. It's a little bit of a rough estimate, I'll say off the bat, because this went on for a while. So I'll get into that in a few slides here. Our illness complaint tool is an online standardized form where we collect both foodborne and waterborne illness complaints from the public. We wanted this to be compatible with our already existing Wisconsin electronic disease surveillance system, which we kind of nickname as WEDS, in part because there was early interest from local health departments for a decentralized state that they wouldn't have to learn any new platforms or look in more than one place to find the complaint data from where they're already checking, which is the WED system for all of our reportable enteric diseases. We just recently launched our complaint system. So this happened earlier this year in the beginning of February. And the main reasons why we wanted to have a statewide complaint tool was to make it easier for the public to report their complaints to us. There are a number of jurisdictions across the state that already had complaint tools, but they weren't always easy to find. You'd have to know which jurisdiction you lived in and then where to find them on the various jurisdiction web pages. And we wanted that data collection to be easier for both the local and tribal health departments. So again, we wanted to make sure that whatever data system we built would kind of roll into what they were already used to using. So we wanted to make sure that we used WED still. And then, of course, we wanted there to be more consistent data across jurisdictions. Again, we had more than one foodborne complaint tool being used across the state. But we found that different jurisdictions were interested in asking different questions of their residents when they had a foodborne illness complaint. So we wanted to make sure that every time we were getting the same information from each of the submitters. So for our system, there's two ways to collect that complaint data from the public. One obviously is directly online, so the complainant can go online and submit their own complaint. But also users can create a complaint in the WEDS platform. So if you're a local health department and someone gives you a call, for example, and you want to make sure that that data ends up along with the rest of the complaint data that you're gathering, you can do that directly in WEDS. So that first way, this is the way that the public would submit a complaint online. On the right hand here, you can see kind of a screenshot of what that looks like to a user. Members of the public can access it from our DHS landing page. The landing page also goes into kind of how to use the tool. We've got some content on why they should tell us about their foodborne illnesses, and then what the public health departments will do with the information once they get it. Once they open the complaint form, again, they'll see questions about, their contact information, their symptoms, details about their illness onset, well dates, and then we do ask them what they think their suspected exposure was, but we also recognize that not everyone can remember, and also everyone's not going to get it right when they attribute a certain location with their illness. So we do also ask for a 3-day food history, as well as other exposures that might explain their illness. We don't have a ton of required fields, and most of those are based on being able to contact that person for more information. So we do request enough contact information to get a hold of them again and complete a 3-day food history if they don't feel like entering that themselves at the time that they submit their illness complaint. The data that we collect was designed to kind of hit all of the high points that are outlined in the C4 guidance for foodborne illness complaint systems. And that's sort of what we built it off of. So again, the local and tribal health departments can also either directly record a complaint into WEDS themselves if someone gives them a call or an email. But they can also continue a complaint. So if someone from the public starts a complaint online, but they, don't feel like filling in the 3-day food history, for example, the local health department staff can come into that same complaint and then continue filling it out with them. If they give them a call and have them on the phone, they can continue that complaint with them. Because we're a decentralized state, we initially didn't ask public health departments to follow like a specific step or series of steps for complaint review and follow-up. Instead, we kind of encourage them to build these things into their already existing system for monitoring and responding to illness complaints from the public. And that went on for a little while, but kind of once we launched the tool and it got going, we did find that there were steps that kind of a lot of the local health departments were landing on, not necessarily in a coordinated way, but just kind of naturally. These were the steps that made sense for them. And so we sort of started echoing that as a use case. So, if you want to do follow-up and you need, kind of a framework to do that, here are the things that we might suggest. And a lot of the public health departments are having their nursing staff review the complaints as they come in, and then complete a 72-hour food history and gather the rest of the details for the complaint if they haven't already. Assess those for, is there an outbreak signal here that's reasonable? And then, kind of as a last step, should I refer this to the environmental health staff for further follow-up with a facility or more than one? Or is there another public health jurisdiction that might need to know that this complaint is out there? So for example, if another public health jurisdiction's facility is named in that complaint, they may need to reach out to them or even share that data through WEDS. And then, of course, at the same time, at the state level, we are reviewing these all as they come in. I am using the royal we because it's me. I do this kind of regularly to make sure that we're identifying any patterns across the jurisdictions, if there are any. And then I might send an email to a public health jurisdiction to flag complaints that seem actionable to me. So since the beginning of February, we've had about 200 complaints that we've received through the system. 48 of those were from group complaints or from groups of 2 individuals or more who got ill. I have flagged about 7 of those for further attention by the health department, but we've had 0 confirmed outbreaks. And I think part of the reason why we kind of have a little bit of a gap there from the number that are flagged to, the number of outbreaks that actually turn into an investigation is, kind of a function of the decentralized state. We can flag these for folks, but it kind of depends on the local health department's bandwidth at the moment and their capacity for follow-up, whether or not that gets, turned into an outbreak and follow it up as an investigation. So I think this will improve over time, but so far we've gotten about 1/3 of those complaints with a completed 72-hour food history. We're starting to encourage the local health departments to get that information if they didn't in the initial complaint. So a few lessons that we've learned along the way is to kind of build off of pre-existing systems and knowledge, again, using WEDS rather than bringing in another data system. We also did direct web-based reporting during COVID. We called it COVID Connect, and that was sort of the way that people could report their symptoms as part of a self-monitoring system. And then we also used a similar type of thing during the Ebola self-reporting of symptoms in 2014. So we were kind of using that pre-existing knowledge to, not have to redo the whole thing. We had lots of groups efforts, and sort of relying on institutional knowledge of different groups across the health department to make sure that we were going about things in the most expedient way and kind of like getting through the red tape that people know about as part of their day-to-day work. We did find that gathering input and making changes early was helpful. Early in our case was about 10 years before it actually launched. So we did have an early survey back in 2014 to gather gauge interest in a centralized complaint system from the locals and then gather information about their systems that they might already be using. And then since then, kind of revisiting with people and since since the tool is launched in February, we've had a number of meetings where we invite people who have been using the tool back to talk about what's going well, what's not going well, gather their recommendations and experiences. And we've done a few of those since we launched. And we've made a number of changes based on that feedback. And then I think, one of the other things that we learned is just to not wait for a perfect process or tool, but to start with good and then kind of work toward best along with your public health partners. So we did, again, at the beginning, we didn't really offer a proposed process for follow-up on these complaints. But I think, since we're kind of landing on a best approach, I think that can be something that's offered up as an option for people if they're starting with a new system and they want to make sure people feel comfortable with it, just kind of offering a best approach guide for follow-up. And then finally, we didn't have a huge budget. So we borrowed lessons that we learned from the vector-borne team here at DPH. And they had found that they got the best return on limited advertising money by using like online content and social media boosts, which are low cost or free. And we've been using those to share the link to the tool and also the content across the state. Oops. So one of the things that we sort of anticipate might be a future challenge is increased reporting or decreased bandwidth. So increased reporting, right now we're only getting a handful of complaints a day, and that seems fairly feasible for one person to review at the state level, but that might change. And then again, kind of thinking about what happens if we have, another statewide or national or pandemic outbreak that we need to focus on, and we have decreased bandwidth to kind of review those. So we're, right now we're relying on the public health staff at the local and tribal level. But, we can't always rely on them having the same amount of bandwidth going forward. And then I think another thing that is a challenge and something that we're hoping to work on going forward is to find a better way to flag actionable complaints. Can we use coding or AI to help us identify records that have something in common? Repeated places don't always get noticed if you're using a standard data analysis tool, just because there's a lot of misspellings and we have free entry. So we're looking to other states potentially for good ideas for finding those records that have something in common. And then, kind of just as a continuing thing, boosting public awareness, I think will continue to be something that we strive for, making sure that, we get the message out in a bunch of different ways and on several platforms. And then lastly, kind of building partnerships with other agencies and groups is something that we'd like to build out a little bit more. We do gather information about symptoms that are more waterborne illness related. So we've reached out to the harmful algal bloom group, for example, and we've chatted with them about letting them know if we see something that looks like a hat-related illness. And then we're also working with the ag department, of course, and making sure that they're kind of in the loop on any facility-specific things that we notice. WEDS is a World Care by Clinicus system. We started, technically we started thinking about this and kind of getting feelers out in 2014. So it's been about 10 years in total. Of course, that hasn't all been development time. We never had dedicated staff for it. And so, we started in 2014. People would work on it when they could, and then COVID happened. And then once COVID was kind of in the rearview mirror, then we could really focus a little bit more. And then kind of between that 2022 and then launch of 2024 was probably when the most or the bulk of the work happened. We had one epidemiologist, that's me. We had a health communication specialist that I worked with on a lot of the content, including, press releases and video and some other things. We had a media content artist that we contracted with to do the video. And then we had people from the WEDS team and the self-reporting module staff that worked with us. Again, this was never, a dedicated project for any one or group of us. And so all of the development and launch time kind of happened within the scope of our regular day-to-day duties. I would say when I was working on it the most, kind of getting all the content together, getting it approved, making sure that all the partners were in the loop and we were gathering input from everybody. I would say that it would be, up to 30 hours a week. But that certainly wasn't the norm. That's probably just the max. And then we had self-reporting staff reported working on this for about 10 hours per week when we were coming up with the development phase. Our media content contractor put together the video within 6 months. Of course, that wasn't always production time. Self-reporting estimated about 400 hours total. And then as far as maintaining, there really isn't a ton of maintenance time. So we do about 1 to 2 hours as needed. And then, we just have the one staff person on the WEDS team. For myself, I usually do about 3 hours per week, and that includes reviewing all of the new complaints that come in and then redirecting those to local health departments as needed. And then, of course, it's difficult for us to kind of estimate the amount of time that's actually spent on reviewing and responding to our system since it's decentralized. Probably the bulk of that time is going to be the public health nursing staff and the environmental health staff at those local and tribal health departments. And I will take any questions on the chat. And here's my contact information if you just want to have a discussion or shoot me an email with any questions. Thanks.
Thanks, Karen. And a big thank you to all of our speakers today. Oh, that was not me that popped up there. Okay. And at this time, we will take a few questions. Our Q&A box has been very active. So if you haven't taken a look there, there's a lot of questions that have been answered. And so for the sake of time, I may take a couple that didn't get answered live. And I also want to point out, if you go into the chat feature, Madhu has summarized just put a statement on there where it goes through each state that presented what system they use, a link to it, and whether they are centralized or decentralized. And hopefully what you gain from this as well is knowing that you can reach out to any of the presenters today to ask them specific questions on their systems. And you can reach out to them directly. If you didn't catch their emails, maybe they could pop them in the chat. If not, you can always reach back out to me. And I can get you in touch with them. And let's see, I'm going to take one. Karen's answering it now. It was one I was going to take or answer live. What constitutes a foodborne outbreak signal? How is this assessed? Do you want to just speak the answer?
Sure, yeah, no
Karen?
problem. So we kind of encourage the local health departments to follow the NORS definition of an outbreak. So really we're saying, your Spidey sense should be up if there are 2 or more people that have a shared exposure, within that 72-hour food history, then with no other suspected shared exposures. And we ask that they look at, the timing of onset and the type of symptoms that are reported to determine if it's sort of an actionable complaint or not.
Great, thanks. And then there was another one that came in that asked about false complaints, or are these systems spammed with non-complaints? And based on the response from Maryland, Aaron in Delaney, Maryland, and Utah, it sounds like they, may occasionally get some spam, but it doesn't seem to be overwhelming. Unfounded complaints, they may come in. But again, it seems manageable, but I'm sure every state is different, but it seems to not be a roadblock at least. While we're waiting for some other questions to come in as well that haven't already been answered, I was just going to share. I will get it in a second. I wanted to share our slide on, if you're interested in this topic, it is our national work group on foodborne illness complaint systems. Trying to move things out of the way here. And you can see that there's a QR code if you want to scan it. In the National Work Group on Foodborne Illness Complaint Systems, it is an active discussion-based working group that covers a variety of topics surrounding foodborne illness complaint systems and processes. And we talk about all sorts of topics that are often based on interests relayed to us through polling or what we hear through our networking with our partner states and jurisdictions. And, you know, we aim to make recommendations to improve outbreak detection through complaint systems, and again, either showcase or discuss different issues that are occurring. And they take place every other month on Wednesdays at 11 a.m. Mountain Daylight Savings Time. So you'll have to do the math to figure that out. Let's see, has anything else come in? Do any systems allow anonymous complaints?
Utah doesn't allow anonymous complaints just because our biggest thing is that we want to be able to follow up with people. We don't want someone to put in that, 30 people got sick at a party and we can't follow up with them at all. But we do have people, we require them to put in their name and birth date, and we have people put in anonymous as their name, and then like a fake birth date. So people will get around it if they're very passionate.
Yeah, that's the same for Maryland, just as Delaney said. Yeah, we require a name, but they just type in anonymous, or sometimes those come in via phone call too. And the person just says, I don't want to give my name or any identifying information.
I can echo that for Wisconsin.
Same for Rhode Island.
Great, thanks. And yeah, I see there were other questions that have been answered in the Q&A. Kind of, does anyone quickly for our last question, maybe there was a few where the theme is like buy-in, whether it was buy-in through the local health department or buy-in how, advertising to the community. Does anyone want to speak a couple things to that? I'm not sure if anyone.
Yeah, sorry. Oh. I did type kind of a partial response to that. We tried to gather input from them early. I guess, that was part of building something that people would want to use. So, doing that piece, and then also, following back up with everybody to see how things are going and encouraging them to use it because it's easier for them to use, I guess I should say. And then, we have worked directly with some of the local health departments that are already gathering complaint data and just seeing if we can get our data systems to align, and kind of working in tandem with the WEDS team to do that.
Great, thanks. And then I do want to post or talk about a couple other things. One is the evaluation. If you attended this webinar, please use this code. Madhu, I think, also posted the link to the evaluation in the chat. But this QR code will directly bring you to a very brief survey, just asking for your feedback on how this course was for you and topics for additional webinars that you'd like to see. And then our final item I wanted to share was just who we are. So again, this was brought to you by the Food Safety Centers of Excellence. We have a website where we house a lot of the projects and products we have developed over the years, foodsafetycoe.org. And then you can follow us on social media, and you can also join our mailing list. So whenever there's a webinar or whenever we post a new product to the website, or if there's a training opportunity, you will get an email, and I promise they are not overwhelming. Sometimes they go to your junk, so you just got to make that rule so you get that, so they go to your inbox. But it's not, you won't be inundated, I promise, in a lot of the items I think you'll find interesting, or their products you yourself requested. And the mailing list sign up can be found on foodsafetycoe.org. Again, I want to thank all of our presenters today. A big thank you. And I hope everyone who attended found it helpful. And please reach out to, you can reach out to me or to the speakers directly if you have additional questions. But thanks so much for joining, and I hope everyone has a great rest of the day. Thank you.